So thanks for joining us this afternoon. I know it's a beautiful day outside, so I appreciate you taking the time for this webinar. So my only disclosure is, as you know, this talk is facilitated by Medela. That being said, I won't be discussing products, and it doesn't suggest an endorsement of Medela. As Susie mentioned, we're going to discuss physiology of lactation. Nothing too complicated or scary, don't worry. We're going to discuss common risk factors that impact lactation, and importantly, to share the evidence, to share the science for a proactive approach to lactation. And all this with the hope that we can share really pretty simple interventions that can help better support our families, increasing mother's own milk, and hopefully improving outcomes. So we'll start with the case. It's purposely a little absurd or a little provocative, not necessarily real life, but hopefully it'll help us kind of discuss, and we'll go back to it at the end. So Shayna is a G1, so she's a prime up with obesity and gestational diabetes, who unfortunately develops preeclampsia. So due to that and worsening growth restriction of the baby, she's induced. When you talk to her before delivery, she says she thinks she'll probably breastfeed, but since she wasn't due for 2 months, she hasn't completely made a decision. So unfortunately, the fetus has D cells, induction fails, and she's taken to section, but fortunately the baby does well and goes to the NICU. So Shayna arrives on the postpartum ward from the recovery unit, and she's told to hand express. She does it a couple times, but doesn't really get anything, so figures it's pretty pointless and stops because it's not working. So the next day, since the baby's doing well, the nurse asks, is there any milk? And they realize there isn't yet, so they bring in a pump for mom. She uses the double pump as a single because it's kind of complicated to hold both parts. She reports a lot of nipple pain, and because it's just really not comfortable, she pumps a couple times that day and then sleeps during the night. However, she is bringing the 5 mL of breast milk that the baby needs for every feed, so she's happy, and the NICU is happy because she has an adequate supply for the baby. She discharged home the next day without a pump, so hand expresses a couple times at home and then goes to buy an electric one the next day. She figures she probably won't need it for long, so she buys just a single pump. And then she finds out if she pumps even less frequently, she gets more milk each time. And that makes her feel good. Her volumes are bigger, so she goes down to pumping 3 times a day. So about a week later, the nurse checks in because they realize they're quickly running out of milk as the baby's feeds have increased. They find that mom's making about 90 mL a day. So then they realize if mom has low supply, they call in the LCs to try to rescue the milk supply. Mom's set up with a hospital-grade double electric pump. She's given good education about how often she should be pumping at night, as well as power pumping to try to rescue her supply. So luckily, she's somewhat able to do that. And after about a week and a half, she's up to 250 mL a day. The baby goes home a couple weeks later on partial breast milk and partial formula. So somewhat of a success story. This mom had a lot of risk factors, and the baby did get breast milk, but clearly there's quite a few opportunities for improvement. And so we'll use this case as kind of a launching point to go into lactation physiology, and then we'll come back to it at the end. So as you probably know, since you're joining this talk, mother's milk is by far the gold standard. It's a cost-effective intervention in sick and preterm babies that really reduces costly and significant morbidities during the NICU stay. And these include bad things like neck and sepsis and BPD. Now in all babies, not just prems, it improves long-term neurodevelopmental outcomes. And this is a dose response manner. So the more milk you get, the better. It also reduces the risks of really common complications like asthma and allergy that we see in the population. And it can even reduce risk of childhood leukemia. It reduces cancer rates in mothers as well as type 2 diabetes in the future. And importantly, and I think this isn't generally known by the community, is that donor milk is not at all an equal alternative. Granted, it's better than formula, but it really doesn't have any of those benefits that I just mentioned with the exception of a reduction in neck. So we really want to focus on how we can get the most mother's milk possible and help mother meet whatever goal that she has after education. So despite these benefits, many Canadian and babies worldwide don't receive either prolonged or exclusive mother's milk. We're pretty good at initiation, but our breastfeeding rates very quickly fall. And at 6 months, when the WHO and other entities still recommend exclusive breastfeeding, only a little more than a quarter of our moms are actually still lactating. And when you ask, it's usually because mothers either subjectively or objectively feel like they don't have enough milk, it's the most common reason, or just general difficulties with breastfeeding. So why is this? I mean, clearly we've been able to get by for millennia without significant supply issues. And so why are we having these problems now, and how can we help support our modern moms? So first of all, a lot of our patients are prems. And so we have to recognize that moms who deliver prematurely really differ a lot from mothers who deliver healthy term babies. It's pretty unusual for a mom just to roll in and deliver a prem out of the blue. Usually, premature delivery is a result of this kind of complex interplay of sociodemographic risk factors. Mom is sick, the fetus is sick, and all of these can affect mother's behaviors. So, whether it's infant led or mother led supply and demand with pumping versus breastfeeding, infant dynamics. So, in most cases, babies and moms are separated. And then the actual timing of lactogenesis due to some risk factors that we'll talk about in a sec. Inadequate breast stimulation, so either by the pump or by a baby who's not latching well. And even incomplete breast development. So a lot of these moms will deliver prior to their full pregnancy, during which time their breasts were supposed to develop further. So what are some of these risk factors? So unfortunately, a lot of these are pretty common. So first-time moms, cesarean section, and then things like obesity, which are becoming more and more prevalent in society. We can't really, at least on a case-by-case real-time basis, do a lot about these things. But what we can affect is this, the timing of first milk expression and how frequently moms are expressing milk. We can provide them with the education and really, again, share this science so they understand the reasoning behind it. There's also risk factors for babies. So as we talked about, a baby born early, or any baby that has problems sucking or latching. So a late preterm baby with a cleft palate, for example. Again, we can't really change these risk factors. But one modifiable risk factor is unnecessary formula supplementation. And this is from a screensaver that we're using right now in our NICU at Sick Kids that I developed. And it's reminding us about the kind of natural process of early lactation. So typically, when a healthy term baby goes to breast, they get almost nothing, like literally drops to a few milliliters of colostrum. And so in this, middle picture here, you can see that's a 5 ml oral syringe. That would be a generous amount for a baby to get with colostrum at the breast. Now, unfortunately, though, when we supplement babies with formula, and granted, there are definitely cases when it's medically indicated, like significant dehydration. But when we unnecessarily supplement, this is what we're giving a baby. We're giving them a huge bottle that's many, many times greater than what they would normally be getting at the breast. So they take this big volume, they're satiated, they're full, and they don't have that same incentive to do that really frequent breastfeeding that babies are normally supposed to do in the first few days of life. So to kind of understand our recommendations, I think it's important to do a really brief review of lactation physiology. Again, nothing in tons of detail, but this is something that I personally don't think I ever learned in medical school or much during PEDS residency or a neonatology fellowship, to be honest. And so this was really eye-opening to me when I started doing research. And so I think it's important to share this. It really helps understand the basis of recommendations with pumping. So during pregnancy, the breast basically gets ready to make milk. The first step is secretory differentiation. So the cells kind of get revved up and start to get that ability to make milk. This is called lactogenesis 1. And actually, the breast starts making milk as early as 16 weeks. However, milk doesn't build up within the milk alveolus because of these leaky areas between the cells. So any milk components that go into the alveolus leak back through, and you can find, for example, lactose in maternal urine when you're pregnant. Now, once you deliver, a whole bunch of complicated hormonal changes occur, typically within 3 days in a term delivery. And the main driver is the delivery of the placenta. So you get this really, really quick and rapid decrease in progesterone levels. Now, importantly, this first step, this lactogenesis 2, is not reliant on stimulation. So even moms that don't plan to breastfeed, most of them do feel their milk come in. However, even though it's not reliant on it, it can be influenced by breast stimulation. And that's been shown, for example, in a paper I'll go over later that I did in Chicago, in which we found that moms of very low birth weight infants who pumped more frequently in the first few days of life had earlier evidence of secretory activation. So how does this work? What exactly is secretory activation? So basically, progesterone, when mom is pregnant, is inhibiting prolactin. Once progesterone goes away with the delivery of the placenta, prolactin is able to close those leaky cellular junctions. Once those tight junctions close, lactose basically gets stuck in the cell. So the spaces between these cells goes away, lactose gets stuck in here, and then it draws water into the gland, and voila, your milk comes in. It's pretty amazing. But that's just the first step. So once mom's milk comes in, the next step of lactation is really coming to volume or making an initial threshold amount of milk, and then making copious amounts of milk that will allow her to feed her baby for weeks or months or even years. Now, this part is dependent on both stimulation and milk removal. So only moms who are stimulating the breast, either with the baby or with a pump, will continue on to this step. Now, importantly, each breast is controlled separately. So if a baby only drinks from one side or mom only pups from one side, only that breast will make milk. And this time between secretory activation and coming to volume is incredibly critical. And I'll go back to this over and over, but this is what I call breast programming. This is the time that you're telling your breast what to do for, again, months and months down the road, not just for these first couple of days. And this is really a time that we can't get back. So it's pretty urgent to have really quality lactation support during this period. So prolactin is critical. Sorry, prolactin is critical. We talked about closes the tight junctions in the cell. But importantly, it also helps you make more milk-making cells. This is really important in moms that deliver early because they might have delivered before their breast completely developed. So they kind of need all the help they can get, and prolactin makes more milk-making cells. It also prevents cellular apoptosis of milk-making cells. So again, you are with higher prolactin, you literally have more ability to make milk. And importantly, high concentrations of prolactin are vital early on in lactation, not as much later, but these first couple weeks are really important. And if you don't get high levels, you can jeopardize milk production basically forever. So how does this work? How do we make prolactin? So these are two old studies, but physiology doesn't really change. And these are showing us that suckling induces a prolactin surge. So in both these studies, you have a small bar on the left, which is the kind of initial level of prolactin in the mom's serum. And the next bar next to it is that big jump that you get with the baby suckling at the breast. And you can see that in those first couple weeks of life, you get a much bigger surge than later on. When you get that prolactin surge, again, it contributes to that feedback loop of breast programming. So you need to stimulate the breast early, often and effectively in these first couple weeks. And importantly, even once prolactin closes those tight junctions, we have found recently that they don't actually necessarily stay closed. So I reported 2 years ago that for the first time, other than in mastitis, we found again that they can open back up if mom's pumping changes. I'm not going to go into tons of detail about this study, but I basically looked at components of milk that indirectly tell me that the cellular junctions are closing, particularly sodium. In this case on the left, this red line is sodium. So when your cellular junctions get tight, sodium levels really quickly drop. So you can see the sodium levels drop. At the same time, mom's volumes, which is in the yellow, goes up. So her tight junctions have closed, her milk came in, life is good. In this example, the mom's sodium didn't drop quite as much, but her volumes are coming up. But what's important is that in this case, so on the upper x-axis here, you see her pumping frequency. It's a little small, but she was pumping 4, 5, sometimes 8 times a day. And over here, on about day 12, she pumped twice. Now you'd hope day 12 you're kind of out of the woods. Not so much. We found that when she only pumped twice that day, and we saw this in multiple moms, her sodium levels immediately shot up to basically the same levels that they were when she first delivered. And her milk volumes then immediately decreased. So they were showing us that these tight junctions quickly opened up with even 1 day of less frequent pumping. So in these first couple weeks, we really have to continue intense lactation support and talk to moms about the importance of this really frequent pumping. So again, in these first 2 weeks, if you remember that prolactin surge, it literally makes more milk-making cells. So the more you pump, the more prolactin, the more milk-making cells you get. And those cells stick around if you keep pumping. But if moms go down in their pumping frequency during this critical window, those cells basically undergo apoptosis and a pruning kind of procedure, which is okay initially because they shall still have a decent volume. But as the baby needs more and more milk, then those cells aren't going to be there later on. And so we really need to reiterate again the importance during this critical period of really intense pumping. And this kind of leads us to the end result of that is that making enough milk for the preterm baby later. So in this visual here, this blue is milk volume, so milk volume on the y-axis and time on the x-axis. So in a healthy term baby, the first couple of days you don't make a lot of milk, but then your milk comes in and then baby's needs kind of slowly increase. Now the issue with the preterm baby is they don't drink very much milk at the beginning, especially a teeny tiny 500 grammer. So all you need is this much milk. But in some point, that prem is going to correct to a healthy term, hopefully healthy term baby, and they're going to need a lot more milk. Now the problem is, if mom has only programmed her breast to make enough milk for a 500 grammer, once that baby corrects to 40 weeks, we're going to have a major problem. We're going to have a lot less milk than we need. And unfortunately, months down the road, it's really challenging to kind of get that time back and to make more milk because those extra cells that we could have made, the body isn't as responsive anymore. So we really have to, again, focus on this critical early window to help all moms program the breast to make what the equivalent of a near-term supply would be, so then they can feed their baby for weeks and months down the road. Which again brings up the importance of meeting a critical threshold. So I usually use at least 500 mLs a day in the first 2 weeks. And I found in a study that I did in Chicago that this was the most important factor that predicted whether babies were still breastfeeding at NICU discharge months down the road. Not any of the other common maternal risk factors, it was milk volume at 2 weeks and whether moms were able to hit that critical threshold. So we know the science behind it. We know what moms need to do ideally to help meet their lactation goal. So how do we kind of translate this into work at the bedside? What can we actually do? So in that critical period, we need to initiate milk expression early, often, and effectively. So what's the science behind that and how do we do that? So in the healthy term baby, breastfeeding as soon as they're born. So breastfeeding within an hour of birth, even if mom delivers via cesarean, and no unnecessary formula supplementation, and rooming in and on-demand breastfeeding. And we know that hospitals that do these things are much more likely to have moms who exclusively breastfeed at discharge, which, although that's a really kind of early marker, is a predictor for long-term lactation. And it can be really challenging with moms who deliver via cesarean to get a baby to the breast within an hour. But it is definitely possible when there's buy-in from different stakeholders within the hospital. I like this paper. It actually comes out of India, and they really felt that, again, it was important to have babies breastfeed quickly. And they recognized that if they waited until mom got to the postpartum ward, they had always missed that critical window. So they designated a person to ensure the infant goes to the breast. That was their job. And similar studies have done the same with making sure that someone helps the mom pump within that hour. They put a medical order in the chart, so no different than a medication. It had to be checked off. Baby went to breast within an hour. And they made sure that baby could breastfeed within the operating room or the PACU, because again, they realized they missed a critical time if they waited for transfer. So in this hospital that didn't have a lot of resources, their breastfeeding rates after C-section went from almost no one to almost everyone within that golden hour. So it can be done. Now, the tougher group is the late preterm or near-term babies. And these babies are really tricky because they look like a term baby. And so everyone kind of expects them to act like a term baby. But they're really kind of, they're fooling us. And these babies have the worst lactation outcomes because I think we don't pay as much attention to them as we should. We kind of give them more credit than they're due. These babies have rapid fatigue with breastfeeding. They don't latch well. They slip off the nipple. And they also don't wake well to demand feed. So it's a more mother-led process. Because of these risk factors, these moms are at a really high risk for a decreased milk supply if they don't pump after breastfeeding. Because if the baby isn't latching adequately, even if they're on the breast for 20 minutes, if they're just hanging out and not actually doing any suction, the breast isn't going to be programmed properly. These moms really need proactive lactation support, especially because they're in hospital often for such a short amount of time. And once they're discharged, it's often kind of too late. So they really need to understand the importance of good breast stimulation and pumping afterwards if the baby isn't effectively feeding. As with term babies and really any babies, skin to skin and rooming in is definitely obviously beneficial to lactation in this population. So how about our small babies? So NICU infants, which is my specialty, we know that mother's milk is provided for longer and at higher amounts if moms start to double electric pump soon after delivery, so within 6 hours. They pump at least 5 times a day. And then kangaroo care and skin to skin also improves outcomes. And the importance of that early pumping, I think, really needs to be reiterated. We have a lot of challenges with that at Sick Kids as a referral hospital because we really don't have access often to moms in those that first day of life. And so it really needs to be a focus at birth hospitals to get moms pumping as soon as possible after the delivery of a baby who goes to NICU. Now, these studies are done by Leslie Parker, who's done quite a bit of work on this topic of when to initiate pumping. She recently published another article just this year, but I'll go over her 2016 article in which she randomized 40 moms to double pump either before 6 hours or after 6 hours of birth. Now, the early group got twice as much milk in the first week of life just from that difference of pumping in that 6-hour window. Importantly, though, they also made more milk 6 weeks later, and they were twice as likely to still be lactating 6 weeks later. So again, that's such a critical time in those first few hours postpartum. Now, in this study, they found the results were really driven by moms who initiated pumping the quickest within an hour. But that 2020 article that I alluded to, she did another randomized controlled trial, and that didn't pan out as much. So it seems that you just really need the first 6 hours, which is good because that's a bit easier. It gives us a bit more wiggle room as providers. She did an earlier similar study in which she found that moms who pumped within the first 6 hours their milk came in significantly earlier, so days earlier, which would be really important for babies getting donor milk versus mother's milk early on. And just like the other study, mom's milk volumes were different from the start, just from pumping within those 6 hours. And they really never caught up. So moms who pumped early, so within 6 hours of life, still had much higher volumes 6 weeks later. In addition, we know that low pumped volumes early on are a strong correlation with long-term lactation. So if we get moms pumping earlier, they're more likely to have more milk by day 4, on which we found that moms have up to 10 times a greater risk of formula feeding if they're making less than 150 mLs a day. Again, those first 2 weeks seem really critical. There's been multiple papers, mine and others, that have showed that meeting that threshold of 500 mLs a day in the first 2 weeks of life really helps determine future lactation ability. So early milk expression and often milk expression. So for healthy term babies, demand breastfeeding. For everyone else, pumping for 15 to 20 minutes every 2 to 3 hours. So ideally at least 8 times a day. Definitely more than 5, but ideally at least 8. And it's important to talk to moms about waking up at least once at night to pump and defining what that actually means. Like night isn't a 12-hour period. Moms really shouldn't go longer than 5 hours. And we've seen in studies that once you go longer than 5 hours, it can really affect volumes, which makes sense. Like if you think about a term baby, they're never going to be sleeping 5 hours at night in those first couple weeks. So we really have to have our pumping really mimic normal physiology of a healthy breastfeeding baby. So early, often, and effectively. So in moms who are pump dependent, they often ask, what kind of pump should I use? And so the answer really depends on what their pump dependency is. This is a nice review paper that one of my mentors in Chicago authored. And it really goes over all the different situations in which moms might find themselves needing a pump. And it really shows which pumps are appropriate for which situation. And there definitely is a place sometimes for a manual pump or a single electric pump. But when moms are pump dependent for lactation initiation, that is a very different category than a mom with established lactation who's just going to run to the store and needs to be away from her baby for a few hours. In the case of lactation initiation with a pump, you really, really need a double electric pump, preferably a hospital grade, but if not, a home pump will do, but double electric. It's really the standard of care for moms whose babies can't feed at breast, and it programs the breast best for long-term lactation. The doubleness, I think, is important to emphasize to mothers. I always recommend the hands-free pumping bras or for moms to make their own with a sports bra, for example, to facilitate that double pumping. And a study a couple of years back found that moms who double pumped versus single pumped had higher volumes in the first 10 days of life, but also for weeks afterwards. Again, looking at that breast programming aspect. And I often tell moms that it might be that you're kind of pretending that you have multiples, even if you don't. So you're kind of fooling your body into pumping for twins, like you'd be tandem breastfeeding, but with a double electric pump. It's also faster for moms in most cases, which is always a plus. Importantly, in this population, again, and with moms that are pump dependent for lactation initiation, in my opinion, hand expression should never be used alone. It is simply not adequate to establish a milk supply. So why is that? Why is hand expression so inferior, especially in these first couple of days? So this is another prolactin study. In this case, we're looking at prolactin levels. So we have baby, a double electric, and then this is hand expression. So you can see in the red circle that hand expression results in way, way less prolactin secretion and way less volume in this study. Here's another study looking at prolactin release. And you can see on the left, this is a baby suckling. You get this nice bump in prolactin. And with hand expression, you get nothing. So suckling or using a pump causes prolactin, so it causes milk production, as well as removal of milk. Hand expression literally just removes the milk that's there, but it really doesn't contribute to that feedback loop to make more milk. And for people that are more visual, having the infant as a gold standard, infants, when they're breastfeeding, are facilitating suction and compression, which then causes the release of prolactin and oxytocin. When you're pumping, you have suction but no compression, unless you're hands-on pumping. If you're doing hand expression, you have compression but not suction. But the suction is really key for that prolactin release. And so since hand expression doesn't release prolactin, it's really not appropriate for this population by itself. There's been a few studies looking at this. So this was actually a study done in an African nursery in which moms were randomized to a few different kinds of pumps versus hand expression. You can see by day 2, moms who were doing electric double pumping already had twice as much volume as hand expression moms. And by 10 days, they were making about 250 mLs more a day, so a big difference. A study I really like, though, was from a couple years ago, in which moms were randomized to either hand express with their very low birth weight infant, or to double electric pump in the first week of life. You can see that with electric pumping, which is these white bars, moms are getting more milk. They made about 3 times as much milk in the first 7 days. But what's really striking and really important, and again speaks to that breast programming piece, is that after a week, moms who were hand expressing were then switched to double electric pumping. And they actually never caught up in volumes. Even if you looked at a month later, they still made less milk than moms who double electric pumped from the beginning. So how do we put this all together? So for a healthy breastfeeding term baby and mother dyad, we want to breastfeed early. We want to breastfeed often. So skin to skin helps facilitate that. And breastfeed effectively, again, with skin to skin, so mom can recognize baby's feeding cues. When you have a baby with lactation at risk, either in the NICU or a late preterm baby, for example, you still want to express early, so within the first hour. So either getting the baby to breast if possible, or if not, to pump, ideally within the first hour. You wouldn't wait to breastfeed a healthy term baby, so we also shouldn't wait to pump if it's possible. So early and often, we want to be pumping every 2 to 3 hours. And if the baby is trying to breastfeed but not latching well, pumping after breastfeeding. And then effectively, again, hand expression alone is not adequate for initial lactation initiation. Finally, when we're talking to moms about this importance of early pumping and early breastfeeding, it's really important to provide reassurance. So when moms are pumping, they can visually see that they're not getting a whole lot of milk at the beginning. Whereas if you're putting a baby to breast, it's kind of less obvious. So we need to tell them that it is normal to make no milk or almost no milk in the first day or 2. When moms see this initially, they think that they are failing or there's something wrong with them. No, this is normal. And we have to tell them that we're not really expecting them to make milk. We're expecting them to try to pump to program the breast. They're pumping for their future baby. I don't care how much milk you make in the first day or 2. If you're pumping a lot, then you should be fine weeks down the road. So that's so important, I think, to share with parents. So once you've established lactation, we obviously want to maintain it, especially preterm babies. They can be in the NICU for weeks to months. And so we want to be able to get moms to still be breastfeeding at discharge and hopefully beyond. So how do we do that? So it turns out that direct breastfeeding is a really critical part of this. And I'll share a couple studies. This is an Israeli study in which 50% of these moms of very low birth weight infants were still breastfeeding after 6 months, which by itself I think is pretty remarkable. So they found, when they looked at a whole bunch of different maternal and infant risk factors, that really only direct breastfeeding while in the NICU was by far the strongest predictor of this continued long-term lactation. And importantly, in moms that never fed at breast, their duration as well as the duration of exclusivity were halved. So really, really affecting the baby's lifelong mother's own milk dose. This has been seen in multiple other studies. So if the baby was ever put to breast or the number of times they were put to breast predicted mother's milk at discharge. One direct breastfeeding a day meant that they were more likely to be receiving mother's milk 4 months later. And in a relatively large American study, they found that moms who exclusively pumped had a much shorter duration of lactation, so about a third the duration as moms who ever put baby to breast after they controlled for other factors. So really speaking also to the challenges of exclusive pumping. So if we're promoting direct feeding at breast, how do we objectively measure intake? So if there are concerns about intake, test weights are a great evidence-based way to look at how much babies are taking. And if you're using specially designed breastfeeding scales, they're accurate to 2 mLs. Even though it seems like some people don't trust test weights, there have been many articles showing the accuracy of them both in the term and the preterm population. And even studies showing that when test weights were used in the NICU, this was a kind of moderately preterm population, babies achieved full breastfeeding at a younger age, and they were discharged home at a younger age, so a week younger, which can be very important, obviously, with limited healthcare resources. So let's go back to our case. So again, we have Shayna, our G1 with obesity and a lot of other risk factors. So in this case, again, supposed to be a little ridiculous, but she has a ton of risk factors. She's a prima, diabetes, obesity, preeclampsia, prematurity. She had a stat C-section. She was undecided on her feeding plan prenatally, and the baby and the mom were going to be separated. Finally, the baby was 32 weeks and was on CPAP, so the baby couldn't feed at breast. So mom is pump dependent for lactation initiation. So how do we support Shayna or anyone in her situation? So early counseling on the importance of mother's milk. So reiterating that this is like a medicine. This is the most important thing that mom can do for her baby. And ideally, early lactation initiation with a pump. So even getting a pump to her room before she delivers, so she's able to use it as soon as she delivers, whether that's vaginally or via C-section. Emphasizing early, frequent, and effective expression with a double electric pump. And reiterating that hand expression, at least by itself, shouldn't be routinely used. And early, frequent, and proactive lactation support. In my opinion, any mom with these multiple risk factors or any mom whose baby is in the NICU is by definition high risk for lactation problems. So not to wait until there are issues, to proactively try to counsel this mom and really closely watch those daily volumes in the first 2 weeks, not just based on what the baby's taking, but based on an overall reaching a threshold for mom. Kangaroo care is always helpful. And then once mom's supply is established and baby is ready, early attempts at breastfeeding, but importantly with pumping afterwards until baby is effectively feeding. So some additional resources as well. All of these kind of thoughts and science they've put together in a publication that I think will be probably coming out this winter in seminars in perinatology. There's an upcoming human milk issue, everything you ever wanted to know about human milk. So there's a particular article about babies in the NICU that I authored, so check that out once it's released in the coming months. But I also wanted to call your attention to this new document from the WHO and UNICEF. So it's a baby-friendly initiative for small, sick, and preterm newborns. So again, specifically either those NICU babies or late preterm babies, and it's an incredible document. It has really all the evidence you could ever want or need put together in one place. There's something like 350 references. It's an amazing review article that also has a lot of practical applications. For example, they have the average volume of breast milk every day in a mom who's double electric pumping, for example. So trying to help healthcare providers know what normal is. In addition, we've kind of put these guidelines together in a best care practices kind of package. So there's one for the NICU, there's one for moms just with risk factors of babies who aren't in the NICU. We've really put together this guide for hospitals to potentially use, starting with informed decision making and going through kind of every step with pumping. And there's checklists for moms, checklists for their partners. So if you're interested in these, please reach out and we can send those to you as well. And finally, again, although I'm by no means endorsing Medela products, their education website is actually really quite helpful. There's a scorecard called Improving the Use of Human Milk in the NICU, and it really closely follows that WHO UNICEF document recommendations. And so I think it can be helpful if you're trying to figure out what to focus on in your unit or in your hospital or what you could improve. And it's a pretty easy scorecard. There's a mother one and an infant one. And again, each section, so time to expression, the time for mom's milk coming in, coming to volume, all of these are very evidence-based from that WHO document. Same with the infant scorecard, the dose of human milk throughout the hospitalization, transitioning to breast. Again, everything is taken from that document. So maybe just a helpful, easy way to kind of look and see what you're doing right and what you could potentially improve. So in conclusion, establishing an adequate mother's milk volume is really the most important lactation-related responsibility for caregivers. And we really have to instill this sense of urgency, not at all just to stress parents. Well, we don't want to do that, but we want to share enough of the science that they really understand this sense of urgency. It's important to educate frontline providers on this as well, to help them understand that waiting a day or 2 or 3 to have this discussion actually is a really big deal. In my opinion, proactive lactation consults are ideal with an LC if you can, but really anyone who has any bedside provider who has this knowledge can help moms get started with early effective pumping. It's important to remember again that lactation initiation is a one-time event. If moms are able to be successful with lactation initiation, they'll achieve full secretory activation. So they'll close those tight junctions, they'll program the breast adequately, and they'll make a lot of milk, and everyone's happy. But if we're not able to support moms adequately, those tight junctions aren't necessarily going to close all the way or not permanently close, which really can reduce mothers' long-term lactation ability. So we really need to figure out how we can best support mother's human milk goals, whatever those are, and then help her meet those goals, both in the short term and the long term. So I know that was a whole lot of data kind of shared, but hopefully that all makes sense. I'm happy to take questions. And this webinar, I think, should be posted. So there is like dozens of references if you are very bored and want to look through this. Otherwise, I will stop sharing my screen so I can see the chat. And I'm also happy to take any questions from an audio standpoint as well.
Thank you so much, Dr. Hoban. As per usual, amazing presentations. I can see in the Zoom group chat that you've got some rave reviews in the chat as well. If anyone
I'm trying to just scroll through to see if there's questions or everyone's saying hi.
Yeah, everyone's just saying how awesome it was. There are no, it was all very clear.
Perfect. Does anyone have, I'm still scrolling. Anyone with any specific questions?
There is a question about the slides being recorded and available to the participants after the presentation. Yeah, and the answer to that is yes, absolutely. We have recorded this webinar, and we can share that link with you guys in an email following the webinar.
I'm just like, I see one question. There's a couple comments about teaching of hand expression. I know a lot of people feel very strongly about hand expression, and I'm not saying to not hand express. I think it definitely has a place, but for moms that are pump dependent for initiation, they really, in my opinion, you need to pump as well as hand express if that's desired. I think there's a bit of evidence that doing both can be helpful, But again, hand expression by itself isn't adequate. And then thoughts about pumping times for multiples. Our hospitals suggest pumping for 30 to 40 minutes. So I've been asked that before. There's not a lot of actually evidence behind pumping for multiples, but I do agree. We do recommend pumping for longer. 40 minutes, it depends on the mom and her comfort level with pumping. Sometimes 40 minutes can cause some breast discomfort. I think we usually recommend 30 minutes, but if the mom can tolerate 40 minutes, that might be feasible. And always double pumping, again, to kind of help the body know that she's pumping for multiples. Sorry, I'm still scrolling down here. Are nipple shields used often for preterm babies to help latch? So I think there's definitely a place for nipple shields for preterm babies. I think every mom is different with kind of her anatomy as well as the baby's ability. But there's definitely evidence in the literature for nipple shields. I think some people feel more strongly about it than others. So I wouldn't routinely use them for every prem that's trying to latch, but I think especially with the help of lactation consultants to help with fitting, et cetera, I think nipple shields can be very helpful to get the baby to breast. Sometimes it can be a bit challenging then to get the baby off the nipple shield, but I wouldn't be too concerned about that. I think there's definitely a place for it. Still scrolling. With access to the checklists. So some of the checklists, like for partners, for example, that are in that document, if you maybe we can post those, or you can individually reach out. But that document that I referenced, I think we can probably, Susie, can we post that? We'll look into that.
Yeah, we can look into that. Yep.
Perfect. Sorry, I'm still scrolling. Thoughts about antenatal hand expression versus pumping in moms who may require supplementation. So I've actually there's been a lot of kind of press about this recently. And I know it's being recommended in parts of Quebec to do antenatal pumping, specifically for moms who are at risk, or babies who are at risk of hypoglycemia, for example, like with gestational diabetes moms. There's, again, not a lot of evidence for that. I think it's a really interesting idea to help prevent formula supplementation, and it can definitely be successful in cases. I am always a little concerned about recommending antenatal pumping because pumping can facilitate labor. It's a natural way to induce labor, as some of you probably know. And so as a neonatologist, I'm always a little squeamish about having moms pump antenatally because I don't want them to go into preterm labor. Once you're past 37, 38 weeks, it should be in most cases safe. And so I think it can be a really reasonable way to build up a little bit of a milk stash to help prevent formula supplementation. And then finally, I should advocate for medical schools to learn basic lactation science. That is very true. I think I learned, like I said, I think I learned nothing about this in medical school. We probably had like a whole day's lecture on like erectile dysfunction and absolutely nothing on lactation. It's infuriating. This is something that almost everyone in the world will either directly or indirectly experience. And I agree. It's something that is not taught at all, either the physiology or just the practical implications of lactation. Totally agree. All right. Is there any, I'm scrolling through, I think I got most of the questions.
Yeah.
All right.
I believe there was one more from Amanda Reed. So why would we teach people to hand express?
It's a good question. I think in some cases, hand expression is definitely better than nothing. If the mom truly doesn't have a pump or a way to pump, it's definitely better to do hand expression than to not be able to stimulate the breast at all. I think a lot of people feel strongly about it because it's natural and it's something very easy that moms can do without any equipment. But I think it's really just kind of become part of the culture because of that. And before pumps were widely available. It's also a lot easier from a hospital administration standpoint, for example, to say, well, mom should hand express rather than really looking into all the infrastructure necessary for example, to have hospital grade double electric pumps available for most moms, which is a bit of a cynical thing to say, I think, but it is just easier, but it's not better for moms. So I think it's really important to try to invest at the hospital level on having these pumps available for moms, and then to really to talk to moms about getting a pump as well for once they're home. Let's see, one more thing. Question. If someone is nursing a toddler when they deliver a new baby, does this affect the colostrum intake for the newborn? That's a really good question. So mom's milk is, as you know, does differ when she's still breastfeeding a toddler, but it does actually change once she delivers a newborn. The body kind of knows that she has a new baby as well. It will, usually her supply is a lot better than with other moms, but it won't be the same. You're correct. The colostrum won't be the same as if she hadn't been breastfeeding, but it does change from that kind of toddler milk. So it's probably, again, not like as good as your colostrum, but her volumes will be better. So it kind of, I think, probably compensates for itself. So we do have those cases every once in a while. And then moms are able to continuously breastfeed for kind of years with multiple children, which is pretty amazing. See someone saying that they often teach moms to hand express with colostrum. And that is true. Like, we encourage moms to pump and then hand express with colostrum. Sometimes it is like really thick and sticky, and it is kind of hard to get out with the pump, and that is very valid. But again, I would do both. Okay. What about the DAME study results regarding antenatal expression that did not show an increase in admission to the NICU or preterm labor? This is true. I think that we do still need to, again, have more studies on this. I think since I take care of mostly prems, it does make me a little concerned in this higher risk population. It is true that the study hasn't necessarily shown that, but I think before we recommend it, generally, we probably need a little bit more data before that's kind of a widely done practice as far as antenatal milk expression. Thanks for the question. All right. I gotten everyone now?
Everything? I think so. I can go back through and kind of, and do a quick review and making sure that we could even compile all the questions and just make sure that we went through all of them. But
and I'm always happy for people to reach out to me as well.
Yes.
With my Sick Kids email, just rebecca.hoban@sickkids.ca. Always happy to chat. This is what I do and what I love to talk about, so feel free to reach out.
Perfect. We'll include that. We'll include your email and your contact in the follow-up email we'll send to all the participants. But thank you so much again, Dr. Hoban. As always, such a wonderful presentation.
Thanks for having me.
We'll see you again soon, hopefully.
Sounds good. All right. Stay well, everyone.
Yes. Thank you so much, everyone, for
Take care. Thanks, everyone.
Day.